Yeah, this is so essentially you're working as a middle grade registrar in a tertiary peds unit, and you've been referred a child, a 5-year-old child called Toby, who is coming here with his who is attending here with his mom. Um, After being referred from GP, who so they have been on a follow up from the neonatal unit to the GP, and the GP has referred it to you after he's heard some abnormal concerns with the heart sounds. Yeah. So
Yeah.
you will be given 4 minutes after this to prepare, and then you will have 6 minutes of examination time, and then 3 minutes of discussion with the examiner. So would you like me to start, or whenever you're ready, we can cut that 4 minutes?
Yeah, let's start.
Let's start. Yeah, that's good. Fine. So yeah, start.
Hello, my name is Ubaid and I'm one of the pediatric registrars. How may I call you?
Hi, my name is Claire, and he is my son Toby.
Well, Claire, very nice to meet you. I'm here to examine Toby here today. Can I proceed?
Yeah, yeah, sure, go on.
Yeah. Hello, Toby. How are you?
Yeah, I'm good, thank you.
Uh, I'm here to examine your chest and do a general physical examination. Can you please show me your hands?
Yeah, sure. So
Uh,
so when he shows you your hands, so this is what you see.
okay. So, yeah, wonderful. Okay, I'm looking for any signs of dysmorphism. I'm looking for any clubbing. I will raise the index finger and see for any fluctuation or any loss of angle.
So no clubbing, no dysmorphisms noted.
And the hands are warm to touch.
Hands up, warm and pink. Yeah.
Yeah, now I'm going to take a radial pulse for 6 seconds.
Yeah, which side?
Um, I'm just doing a radial check on the right side.
Okay.
And
So
now I'm
yeah, you cannot when you check for radial pulse, it's not easily appreciated.
okay. Now I'm going to check for the brachial pulses on both sides.
Yeah. So there is you can feel for the brachial pulse, and the pulse
Okay.
is regular and normal in that volume.
Okay. Any delay on the left side?
The brachial pulse between both
Yeah.
the no, there's no delay.
Okay. Fine. Now, can you please can you I am going to check your eyes. Can you please look to the roof?
Yeah.
I'm going to pull down the.
Yeah, so that's fine. Yeah, there's no pallor, and you cannot see any
Okay.
yeah
Now,
abnormal.
can you please stick out your tongue for me?
Yeah, so the Toby sticks out his tongue, and you can it's normal pink tongue.
Can you please show me your teeth?
Yeah, so his teeth, uh, the he's got most of the teeth, and the oral hygiene appears to be good.
Okay, perfect, excellent. Now I'm going to have a look at your ears and your eyes, um, and look around for any signs of dysmorphism, any small jaw or depressed nasal bridge, low set ears, um, and
Yeah,
then
so
I'm going.
there's no abnormalities there.
Okay, now I'm going to look at the neck, see for any webbed neck, um, look for any raised JVP, and feel for any carotid thrill.
So there is no visible pulsations, no raised JVP, and no carotid thrill or pulsations felt. So carotid pulsations are present, but no carotid thrill or bruit.
Okay, perfect. Now, Toby, would you mind removing your shirt if I could have a little look at
Yeah.
your chest?
So Toby removes his shirt, and you can see that
Okay, now I'm going to look from the bed and to the symmetry, any visible pulsations, any scar marks, stria, any pectus granitum or excavatum, any scar marks of any drains, and then raise both his arms and look for any for the axilla and lateral thoracotomy scars on both sides.
Yeah, so when you inspect the chest from all the sides, the chest appears normal in shape and size and in any symmetry as well, and there's no medical device attached, and there's no scar marks or dilated veins or sinuses.
Okay, any shield chest, any
Normal shape, normal shape.
normal shape.
Yeah.
Okay, perfect. Now, Toby, I'm going to feel your chest, and if you are uncomfortable, you can tell me. Now, I'm going to palpate for the apex beat on the right side and simultaneously on the left side,
Mm-hmm.
um,
So
and
you note
find
that
out
the apex, yeah, you note that the apex beat on the left is on the left hand side.
on the left hand side, and I'm going to count the ribs to determine at which intercostal space is this apex beat, and
Mm-hmm.
compare it with the clavicle so that I could find that whether it is midclavicular or displaced.
Yeah,
And
so it's apex beat is in the mid clavicular space, slightly lateral to the mid clavicular space in the fourth intercostal space.
okay, so is there any visible heaving? I'm going to look for it, and then I'm going to feel for it along the apex, and then along the left sternal border and the right sternal border, and any heaving or any thrill at the at the second intercostal space, both on the right and the left.
Uh, Sorry, so the 6 minutes is over, but we'll just continue because you are verbalizing your examination. So yeah, so when you feel for um, thrill, there is no thrill present in the apical area, but you can feel for but when you place your the pulp of the fingers on the left second intercostal space, you can feel a thrill, and you can also appreciate a heave when you place your ulnar border in the sternal area of the chest along the lower left sternal border. You can appreciate a mild heave
On the left side,
on the left head on the sorry, on the parasternal, right parasternal area.
right parasternal area.
Yeah, yeah.
Okay, perfect. Um, now, now I am going to palpate.
But the
I'm
yeah,
going.
just reminding you, the thrill was in the left second intercostal space. Okay.
Okay, okay. Now I'm going to auscultate, starting from the apex, and
Yeah.
then coming to the right, left lower sternal border, and
Mm.
then the upper left sternal border, second intercostal space, and then the right second.
Yeah. So when
Second.
you place when you place your stethoscope, you hear this murmur, which I'm going to just play, and I'll tell you which area it is. Yeah. Just tell me when you hear it. Okay.
Okay, this is ejection systolic murmur.
Yeah. Fine. So do you want me to stop it? Yeah. So this is best heard again in this left second intercostal space where you heard the thrill.
Okay, and is there
It's also it's
any
also radiating.
carotid bruit or any um, um, murmur in the carotids?
So you cannot hear any radiation to the carotids, but you can hear the murmur radiating to the precordial, rest of the precordial area, which is in the right, the parasternal area, the lower left sternal border, and the mildly in the apical area as well. And when you auscultate in the back of the chest, you can hear the murmur radiating to the back as well.
Okay, perfect. Now I'm going to listen to the bases of the lungs on the back, and look for any scar marks, stria, just like any of the normal observation. And then I'm going to ask Toby. Toby, could you please lie down a bit, slip down the bed, and I would I'm going to feel your tummy. Is there any pain on your tummy?
No, so there's no pain elicited, and the base of the lungs are clear.
Okay, perfect.
So
Now
yeah,
I'm going
can
to
you
palpate.
summarize your examination findings? And because you will not have enough
You will
time
not have time.
after
Okay,
this.
okay, okay. So I examined 5-year-old Toby, um, uh, who has an incurved uh, uh, curved thumb and index and little fingers, and the radial pulses were difficult to palpate. The brachial pulses were bilaterally palpated. Ideally, I would like to have his blood pressure examined, and along with that, I would also like to have had the femoral pulses and look for any radiofemoral delay. There are no dysmorphic features on the face, no web neck. There on The chest is appearing to be of normal shape, and the apex beat is lateralized to midclavicular line in the fifth intercostal space. There is a left parasternal heave in the on the lower sternal edge, and a palpable thrill in the left upper sternal border, and a carotid thrill as well. There was an ejection systolic murmur, grade 3 to grade 4 ejection systolic murmur, radiating to on the left second intercostal space, radiating to the neck.
Mhm.
Um, and um, yeah, uh, so um, this is most likely a pulmonary due to pulmonary stenosis. Um,
And
mo-
yeah, continue.
Pulmonary stenosis, valvular pulmonary stenosis, most likely due to mm, maybe Noonan syndrome or something.
Okay. And what? How would you proceed, or how would you manage this case?
Um, well, uh, I would like
And
to.
what do you think is going on? What has what do you think might have changed that the child has been referred to you? And yeah, how would you manage?
Uh, well, um, what has changed? I'm afraid I don't have an
No
answer.
problem, no problem. So based on your assessment and examination findings, how would you manage, and what are your
Um,
concerns?
I
And
would, I would like to, I would like a referral to cardiology in this case, and do an echocardiography, take an ECG right now, and do a baseline bloods,
Mhm.
um, including FBC and um, renal function tests and UNEs and liver function tests. I would like to, um, and then depending on the results of echocardiography, um, uh, depending on that, I would also like to involve geneticists, um, and um,
so what? Fine. So what do you expect when you do in when you said you would be doing an ECG? What do you expect broadly the features in ECG based on your
um, on the ECG, I would look any um, for any tall P waves, um, given the fact that there is a pulmonary stenosis, um, and since there is deviation, I'm going to look for any axis deviation, any signs of ventricular hypertrophy on the ECG.
okay? And yes, so you organized for an ECG and echo, and you will be doing the basic bloods. So and any other uh, team you would like to involve?
I would, I did.
So this was part of the detailed CVS discussion in one of our online sessions.
So here we can see the candidate had described really well, but what are the shortcomings that he could have improved on, we will discuss in the rest of the section. And in the subsequent clip, I'm going through the structured examination of approach to cardiovascular station. You've done the introduction and rapport building. You look around the patient again for any medical devices, medical equipments. And then you look at the patient if the patient is well and well. So especially in cardiac instances, if you have a small baby, they can be tachypneic. We have to mention that. So well and well, and their growth or nutrition. And you would also like to the growth charts. Don't miss your growth charts. So in this instance, the child was underweight, plotting less than the 10th centile for height and weight. So you would like to make that comment at this point and look for any dysmorphism. So these will not take much time. It will take less than 60 seconds, and you will cover a lot of things which is present in the examiner's answer sheet that the person is introduced. The person has looked for any, if there are any medical equipments, you will likely to pick them up, even like medications like diuretics or a vitamin or a high nutritional energy formula and things like that, which if you are not looking, you will be missing it for sure. And then the growth charts, well or unwell child. This will help you in summarizing as well. And then you begin your examination. So the examination sequence is hands, um, then arms, face, neck, and then you proceed on to the chest. Here are the few snippets of the other discussions that followed in our clinical session.
Sorry, but you mentioned that the radial pulse was impalpable or something.
Yeah,
I
the
don't
radial
understand
pulse was
the sense of.
so he Dr. Obed, when on examination, he specifically mentioned that he's feeling for the radial pulse in the right hand, which he will be doing in which anyone will be doing in the actual examination. But what you need to do is feel for the radial pulse in the other hand as well, and look for radial delay as well, apart from radiofemoral delay. Okay, so on the left hand side, the radial pulse in this instance was completely absent.
Okay.
Okay. Yeah. And ASD can cause an ejection systolic murmur in the pulmonary area or left diaphragmal area and can cause split, S2 split. What Dr. Rice was trying to make Ubaid say in ECG, what would you find? So if he had thought of this, you should think of like right bundle branch block. Yeah, we'll come to that. Okay. Yeah. So let Dr. Rice finish hands, arm, face, neck, and chest. And I wanted to add something else. Let Dr. Rice rather than jumping into I think it is pulmonary valve stenosis and could be Noonan syndrome. Pulmonary valve syndrome can happen in a normal child as well. It need not be Noonan syndrome. Okay, but when I actually didn't see the hand deformity, so now only I've seen. So it's always better if you don't know the syndrome, just say it is. I would suspect a syndromic association in this child.
To find out the exact case discussion and what anomaly and what condition was it, and a thorough discussion on how to do and how to approach a cardiovascular and how to prepare for this station in your MRCPCH exams, please contact us or leave us a message, and we hope to see you on the other side. Thank you.